So this is a study. We looked at patients that were treated at our institution, the Medical College of Wisconsin, between 2011 and 2022. So these are patients who are young, fit for standard induction, which here would be 7 and 3. And what we looked at were patients who, amongst their mid-cycle marrow, had evidence of persistent disease. And so we defined that as greater than 5% blasts on a marrow performed between 14 and 30 days, where the treatment physician determined that additional therapy is necessary. Prior to 2017, these patients largely received a second induction, whether that be 7 and 3 or 5 and 2. At our institution, most people receive 7 and 3. But after 2017, what the big advent was additional options, so lower intensity treatments that potentially have a good opportunity to control disease. So IDH inhibitors came out, venetoclax combinations sort of came out at that time. And so what we know about those agents or those treatments is certainly from an intensity standpoint, does not really yield sort of, as deep sort of cytopenias as we see with giving another induction. These are treatments that, potentially could spare some toxicity. And so increasingly after 2017, for patients who have been in the hospital for a long time, if they had either adverse risk disease, which we worried would not be quite as responsive to a second induction, or if patients incurred toxicity with their first induction, which would make second induction a little bit more dangerous, increasingly what we did at our practice was we would offer them a lower intensity option. So if they had an IDH mutation, we would give an IDH inhibitor plus minus azacitidine. If they didn't, then we would offer a venetoclax combination, either ven, vidasa, or venetoclax and decitabine. And so what we reported were first, what was the safety profile of giving a lower intensity reinduction versus giving standard reinduction with 7 and 3. Second, what were the outcomes? Did we lose anything by giving this lower intensity reinduction? And so firstly, what we found was comparing patients who received standard 7 and 3 again versus patients who mostly received venetoclax combinations. There was a tremendously lower amount of time that was spent in the hospital if they were to have received a lower intensity reinduction. And so patients who received 7 and 3, we looked at how many days they were in the hospital over the next 30 days. And essentially, the average amount of time in the hospital was about 30 days. And so giving another induction really keeps patients in the hospital long-term for another several weeks. Whereas patients who received this lower intensity reinduction, they were in the hospital on average about 6-7 days. And so significantly greater amount of time out of the hospital with this approach. In addition, we looked at transfusion burden. And so we found significant decreased amount of platelet and red blood cell transfusions necessary amongst patients who received a lower intensity reinduction. And we looked at rates of febrile neutropenia, which were significantly lower. We did have a similar rate of ICU admissions, but overall it was low between both groups at around 2%. So, our first sort of assessment in terms of burden on patient, we truly felt that this lower intensity approach kept patients out of the hospital longer and required them less transfusion visits. Secondly, we looked at outcomes. So we looked at what proportion of patients were able to achieve a remission, with the second treatment, and what their survival was long-term. And so what we found were very comparable remission rates between patients who received a second cycle of 7 and 3 versus receiving a venetoclax combination. Somewhere in the range of about 70% in both arms were ultimately able to achieve a remission. There were no statistical differences between the group. In terms of looking at survival, we looked at 1 year, 2 year survival, and we found very similar survivals regardless of which approach was taken. So survival was around 50% for both groups, and that survival was maintained close to about 40% at 2 years amongst both of the groups. So our conclusion, at least looking at our practice, was that potentially with a lower intensity reinduction for patients who, additional hospitalization would be difficult, which is probably most patients, a lower intensity reinduction certainly offers an avenue where prolonged hospitalization is less likely. Furthermore, transfusion burden appeared to be less. That's certainly a significant issue for patients, coming into the clinic or the hospital, requiring frequent transfusions. So overall, our conclusion was that these lower intensity options represent, potentially a more patient-friendly way of potentially putting these patients into remission and allowing for adequate disease control. And so certainly a hypothesis-generating study, whether that should be considered as a standard option for patients who fail to achieve induction remission with their first induction. Certainly at least something you can kind of bring to the table when you're discussing with patients in terms of next steps if they have persistent disease.